Well, what an amazing day so far, and the brilliance is not anywhere near an end because we've got two fantastic speakers to give us some really important talks. I'd like to welcome Andreas Metzner from University Medical Center Hamburg and Atul Verma from Toronto, Canada. First, Andreas is going to talk about minimizing complications for atrial fibrillation.
Yeah, first of all, Richard, thank you very much for the invitation. I'm happy to be here. My minimizing complications for IF ablation. That are my conflicts of interest. I mean, the easiest answer on how to minimize complications from IF ablation is probably great. However, that's the solution. So first of all, we know that the of complications is rising over the last years. As you can see here on this slide, it's rising because patients are getting older and older, and we do also more complex procedures. And another reason is certainly that also the incidence of comorbidities rises. As you can see here stated on the slide, the incidence of coronary artery disease, congestive heart failure, lung disease, also of kidney disease rises. So what are potential complications in atrial fibrillation? First of all, it's vascular complications. It might be cardiac tamponade. It can also be pulmonary vein stenosis, symptomatic or asymptomatic, and it can be atrial to esophageal fistula, and finally also TIA or stroke. I would like to start with the vascular complications. In the worldwide survey published by Riccardo Cappato, the incidence of vascular complications was about 1.5%. And the question is, how can we further reduce it? First of all, what is the impact of the sheath size? We know from the Fire and Ice trial, where we randomized patients to radiofrequency ablation or cryoballoon ablation, that the impact of the bigger sheath is probably not as severe, because we have seen in this trial that numerically, at least, the incidence of groin side complication was even less in the cryoballoon group as compared to the RF group. So the size probably does not matter. However, how to further reduce and minimize complications regarding groin side complications? It might be the impact, or it might be ultrasound-guided venous puncture. We all know that the anatomy is not always the same. So sometimes the vein might be underneath the artery. It might be even more lateral. And so ultrasound might have an impact. And we know from multiple studies that the axis is very safe, and we can further reduce groin side complications by using ultrasound. In this study here, just published recently, a total of more than 1,000 patients was included. And finally, the authors stated that regarding major complications and using ultrasound, the incidence can be dramatically reduced from 1.7 to 0%. So there's certainly an impact of ultrasound-guided venous puncture in prevention of groin side complications. Another aspect is certainly the usage of venous closure systems. There are multiple on the market nowadays. One of them is the Westgate system, which was recently evaluated by Andrea Natale. And first of all, they could assess that the total post-procedure time was significantly shorter by using this vascular closure systems. I'm sorry, it's a little delayed. So a shorter total post-procedure time, and also the time to discharge eligibility was significantly shorter. And finally, they had to assess that there haven't been any severe complications in using manual compression or also the vascular closure system. But regarding minor complications, there was certainly a benefit for using those closure systems. As you can see here, they came down from 2.4 to 1%. And finally, as we have also seen in the previous live case, it makes sense whenever using big sheath to perform a figure of 8 suture. So whenever we go at our center for cryoballoon ablation or laser balloon ablation with a big sheath up to 15 French outer diameter, we always go for a figure of 8 suture. And also based on multiple studies, we know that it's beneficial, that it's safe. Here's one study just recently published showing that the incidence of hematoma by using this figure of 8 suture is very low. Coming to the next point, which is pericardial tamponade. We know again from the worldwide survey performed by Riccardo Cappato that the incidence is about 1.3%, and the question is how to further reduce it. First of all, potential for pericardial tamponade is transeptal puncture, and it should be as safe as possible. What we do at our center, and I guess most centers in the world, is to use diagnostic catheters, especially the CS catheter, because it gives you some additional information about the anatomy. Based on the movement of the CS catheter in your sheath, you can nicely assess whether you're in good contact to the septum or not. You want to see the synchronous movement. You might also consider using pressure control or TE or ICE guidance, as we have seen in a previous live case. Secondly, it's the catheter manipulation, which should also be as careful and safe as possible. And for that, you need a good understanding of the left atrial anatomy and of the PV anatomy. You should always secure your sheath and also balloons by using wires and the Achieve catheter. And finally, and that's a question and a point I would like to put a little more time on, is the ablation tool and the ablation system which is used. So far, the impact of contact force on safety was not yet clearly demonstrated. And I also have some studies. Here's a single center study from China with more than 5,000 patients, half of them treated with a contact force catheter, the other half with a non-contact force catheter. And regarding the incidence of pericardial tamponade, you see that there's a significant difference favoring non-contact force catheters. I'm sorry, I have to go back one slide. So the incidence when using non-contact force catheters was 0.44% as compared to 1.07%, which is statistically significant in favor for non-contact force catheters. However, the data is not consistent. Here's another meta-analysis of more than 34 studies included and more than 5,000 patients. And finally, the authors concluded that there was no significant difference in the rate of cardiac tamponade between the two groups. And we also know from other studies, this is an analysis from Frankfurt again, that when comparing radiofrequency with cryoballoon ablation, there's also a difference, since the incidence of pericardial tamponade when using a balloon technology is extremely low, was 0.1% in the study as compared to 0.8 in RF ablation. We have to admit it's a very experienced center, and in less experienced centers, the incidence of pericardial tamponade might be even higher. However, also here the data is not consistent when demonstrating other studies, such as this one here by Andrea Natale. There was no difference at all between cryoballoon ablation and contact force guided RF ablation regarding the incidence of pericardial tamponade. However, there was a difference when comparing low volume centers with high volume centers. So low volume centers defined as less than 20 RF ablations per year, atrial fibrillation ablations. The incidence of severe complications and especially of pericardial tamponade was significantly higher. It's also the ablation strategy that further contributes to the incidence of pericardial tamponade. And once again, I would like to cite a study from Frankfurt showing that whenever you go beyond PVI by performing linear lesions, cafe ablation, whatever, also the incidence of pericardial tamponade increases from 0.8 to about 3.2%, which is again statistically significant. Next point I would like to focus on is PV stenosis, and the incidence of PV stenosis requiring intervention in worldwide survey is 0.3%. It's low. How to further reduce it? It means we need a precise understanding of the anatomy and of the transition from the PV into the left atrium. We know from the Fine Eyes trial again that the incidence of PV stenosis is very low in radiofrequency ablation in experienced hands as well as in cryoballoon ablation. In both groups it was 0. However, we also know from another analysis, and that's an analysis from Frankfurt again with more than 350 patients treated with RF, cryoballoon or laser balloon, all patients coming back with recurrence of atrial fibrillation, having a second procedure, that the incidence of severe PV stenosis defined of more than 75% stenosis is extremely low in all groups. However, when going to mild stenosis, there's clearly a benefit for cryoballoon ablation and for RF ablation as compared to laser balloon ablation, but the incidence of mild stenosis is extremely low in cryoballoon ablation and the lowest of all three systems. What we do at our center to prevent any PV stenosis is that we try to get a precise understanding of the anatomy by performing PV angiographies, and according to the information that we get from the angiographies and the electrical information, we precisely mark the transition from the PV into the left atrium and ablate there. If you do not go for PV angiographies, you might also consider performing pre-interventional MRI or CT scan that you can later on merge with your CARTO maps or your 3D maps. Last point I would like to focus on is atrial to esophageal fistula, extremely low, but oftentimes fatal, 0.04%. How can we prevent it? Nobody knows exactly how a fistula happens and develops. However, we know that we should try to prevent any thermal injury inside the esophagus when using our ablation systems. For cryoballoon ablation, it's very safe and very clear that there is a correlation between the temperature that we measure inside the esophagus and the incidence and the quality of thermal lesions. And we should consider a cutoff of 15 degrees Celsius. However, it's different for RF ablation. We know there's an ongoing debate on whether we should use a temperature probe or not. That's recent results from Frankfurt, the OPA trial. In total, 180 patients, 90 randomized to a group where no temperature probe was used. In another 90 patients, it was used. And according to the temperature, the cutoff was 41 degrees. The energy has been titrated to 25 to 30 watts when the temperature probe was used, and only regulated to 25 watts when no temperature probe was used. And that's the results that I would like to share with you. There was no difference at all. So there was no impact of using a temperature probe regarding the incidence and also the quality of thermal injury in RF ablation. And that's something we also know from our personal experience. There's no correlation of temperatures that you measure and the incidence, and especially the size of thermal lesions inside the esophagus. Finally, the technology can only be as good as the operator, and so it's very crucial that first of all, we have to gain as much experience as possible. We have to know our limits, and finally, we should discuss our complications and learn from them. That's what we always do when we have a complication at our lab. We discuss it and try to learn from it. My conclusion, prevention of groin side complications, please consider using ultrasound-guided puncture, closure system, or the figure of 8 suture when using bigger sheath. Prevention of cardiac tamponade, only PV at first ablation attempt, preferably with a cryoballoon. Data on safety or contact force guided ablation is inconsistent. Prevention of PV stenosis, we have to have a precise understanding of the PV ostium by performing selective PV angiographies or cardiac MRI. And finally, prevention of esophageal thermal injury. Use of temperature probe in cryoballoon ablation is, I think, mandatory, while reducing energy along posterior wall during RF ablation is certainly very beneficial in reducing thermal injury. However, using a temperature probe in RF ablation is potentially not of benefit. Thank you very much.
Fabulous talk, Andreas. That was super. A really great summary of the issues involved in complications. Now we're going to move on to Atul Verma, who's going to talk about persistent AF management and what the trials tell us. Thanks, Atul.
Hello, everyone. And first of all, Richard, I must compliment you on what a high quality, wonderful program this is, and the production values are very impressive indeed. So thank you very much for making me a part of this. Today, I'm going to be talking about ablation of persistent atrial fibrillation and some of the current approaches that we are using. These are my disclosures that you should be aware of. So I think most of you are all too familiar with this data, which is now hard to believe, over 5 years old, but this is the data from the STAR-AF2 trial, which suggested that there was no benefit of additional ablation for persistent atrial fibrillation. I do put the caveat that that was using linear ablation and fractionated electrogram ablation, which today is not used to the same extent. but I do think this was an important reset for the field because it got us into looking at all kinds of other newer technologies that perhaps are going to influence our ability to get better outcomes in persistent atrial fibrillation. And one of those newer technologies was the implementation of contact force, because as you know, the STAR-AF2 data did not use contact force sensing catheters. And how would contact force potentially change the results of STAR-AF2? So we followed up STAR-AF2 with the TOUCH-AF trial, which used a minimal lesion set, basically wide antral PV isolation plus a roofline for persistent atrial fibrillation patients. And what was quite impressive is that our one procedure success rate on drugs was 71%. Contrast that with STAR-AF2's on-drug success rate of about 50%. So just the implementation of better catheter technology and more durable lesions seemed to make an appreciable difference in the success rates that we would otherwise observe. But what was also interesting is that when we looked at the success rate after more than one procedure, where we just again did the same thing, wide antral pulmonary vein isolation plus a roofline, it was interesting that we saw the two procedure success rate wasn't all that different from the one procedure success rate, implying that you can do a PVI over and over and over again, and you can get the perfect PVI, but still you're not going to achieve 100% success. And there seems to be a plateau to the success rate that you can achieve with PVI alone. So the question is, what are some other potential targets beyond PVI that we can look at? And after STAR-AF2, we tried to look at whether or not certain subsets of CAFE could be interesting. And today, with spatiotemporal dispersion, people are focusing on areas with continuous fractionation. But when we actually studied this back in 2014, we found that targeting continuous fractionated areas in addition to PVI did not seem to improve the outcome compared to traditional fractionation areas. So I'm not sure that was really the right answer. Of course, back in the mid-2000s, there was a lot of interest in dominant frequency, and Felipe Atienza from Spain did the somewhat definitive radar trial in which they looked at dominant frequency. And certainly in persistent atrial fibrillation, he showed that when you combine dominant frequency with wide antral PV isolation, there really didn't seem to be any major advantage. So certainly history is littered with a number of potentially interesting but eventually unsuccessful techniques for persistent atrial fibrillation, and so the search for new targets has begun. And certainly here I've summarized some of the newer approaches that are being used, whether they be rotational or focal activations, scar-based mapping, new CAFE subsets, non-PV triggers, and of course posterior wall isolation. And so the question is, where are we in the current state of play? And it was this trial, the earnest PVI trial, which was presented as a late breaker at ESC 2019, was of great interest to me because this trial compared PVI alone versus PVI plus in a patient group of persistent atrial fibrillation. And they kind of allowed anything you wanted to do in the PVI plus group. So you could do linear ablation, CAFE ablation, you can do both. And what was interesting is that in contrast to STAR-AF2, they actually showed that there was a small benefit to additional ablation compared to the PVI alone group. And this is one of the first trials that actually showed that. In fact, their primary endpoint was looking at non-inferiority, so they showed that it was non-inferior, but in post-hoc analysis, it certainly looked as though PVI plus was doing better than PVI alone. So what are the dominant trends today that we are seeing with persistent AF ablation? Well, one trend, or option one, is dynamic simultaneous mapping during atrial fibrillation, trying to identify so-called focal or rotational sources during atrial fibrillation. And of course, this was very popularized by Topira, but then there have been a number of other systems that have looked at this. Of course, when Topira was evaluated in the larger REAFFIRM study, which was presented at HRS late breaking trials in 2019, they disappointingly showed that firm ablation in addition to PVI did not do any better than PVI plus other techniques for persistent AF ablation. The problem is I really wish they had compared it to PVI alone, because by allowing operators to do whatever they wanted, it became really a very contaminated data set. So, we then can take a look at some of the subsets from REAFFIRM, and what we see is that the PVI alone group seemed to do the worst. It was actually the group with PVI firm that seemed to do the best. And then when you started adding too much extra ablation, again, your success rate dropped. So there does seem to be a signal that rotational activation, focal source targeting could work. Of course, there's substrate-based ablation, where you can define scar regions of the atrium based on voltage mapping, and then you can either homogenize or box isolate those areas. The largest trial to date is the Stable SR study looking at this strategy, and they showed that there really was no difference when you looked at a scar-based ablation strategy versus PVI alone. So that really doesn't seem to have panned out. And then isolating the posterior wall is, of course, another very important technique. And there haven't been any definitive randomized trials to date, although there are some trials in process. And certainly when you look at the meta-analyses, there seems to be a trend towards benefit, but again, a lack of detailed data. I'm going to quickly review some of the dynamic ablation data, looking at rotational and focal activations. And I just want to say that I have now used a number of different technologies to look at this, whether it be CardioFinder, CardioInsight, Ablicon, or Acutus. And it's interesting that in contrast to Topira, most of these other newer systems are actually seeing fairly consistent findings. And when we looked at the Acutus system, for example, and looked at the single procedure success rate of combining PVI with targeting these source ablations, we actually found that the success rate was quite decent at about 70% at 12 months. So this certainly seemed to suggest some benefit. And I apologize for the incorrect reference at the bottom of the screen. This study was published in CircEP, not the New England Journal of Medicine. So I think we need to reevaluate what we are doing today in 2020 for persistent AF, and that's why we are in the process of starting the STAR-AF3 trial, where we're going to be comparing wide antral PVI to PVI plus posterior wall isolation to PVI plus elimination of sources, either rotational or focal sources. And I think hopefully this will provide some interesting results for the field. So at this point in time, I'd like to thank you very much and return the show back to Richard.
Fantastic talks, guys. And I have one question, the same question for both of you. So Andreas has shown us that the more ablation you do, the higher the chance of complication, particularly tamponade. And you have shown us that there's still no convincing data to suggest we should do more than PVI. So Andreas first and then you, Atul. What would convince you to say, if I had persistent AF, I'm going to do more than just isolate the veins? And should we just be isolating the veins at the moment?
Yeah, it's a very interesting question, and it's a great debate, an ongoing debate. Currently, our first-time approach, even in persistent AF, is pure PVI, because as nicely shown in the previous talk, we first of all know it's in many patients not enough. Many of those patients having only PVI develop recurrences, but at the other hand, we still do not know which of the additional ablations that can be performed is superior. But I completely agree, if patients develop recurrence of atrial fibrillation after previous PVI and the PVs are still isolated, we have to do more. And we also do more at our center currently. It's a substrate-based approach. That means according to the substrate that we can identify, we would go at least for linear lesions, in some selected patients also for café ablation. And I'm really looking forward to get more data about, for example, focal ablations, rotational identification of areas in ablation and so on. But currently at our lab, we stay with PVI as a first-time ablation approach.
Yeah, I think, Richard, it's a great question. And, Andreas showed some excellent data about how we need to temper our enthusiasm for additional ablation by weighing it against the risks of that additional ablation. And so I think that, what would convince me to do more? I would be convinced by clinical trial data that says definitively that, yes, if we add further ablation, we are getting further benefit. And then we have a means by which to measure the additional risk against the added ablation that we are giving to the patients. But I also completely agree with Dr. Metzner's presentation that experience matters. And, as we move into an era where persistent AF is going to be more and more targeted, and we potentially need to add further things than PVI, it would be my belief that it's really the high volume centers that should be focusing on these types of patients. And, it's either the paroxysmals or persistents who just are going to get a PVI alone that maybe should be focused on by other centers. And when they fail PVI alone, go to the more experienced place for the additional ablation.
Great. Thank you very much, both of you, for wonderful talks. Well, I very much hope that you've all enjoyed the sessions today. We've seen a number of ways to skin the cat, so to speak, pulmonary vein isolation done in several novel ways. And I must say it's been a great privilege for me to be part of this program and work with such brilliant electrophysiologists. On behalf of myself and my co-course directors, I thank you very much for joining us. I really hope you join us tomorrow when we have another exciting program of complex ablation. And for tonight, or this morning, depending on where you are, I wish you goodbye.